Well, thank you, Andy, and thanks for the opportunity to launch this ambitious and hopefully very useful series. I'm Durado Brooks. I'm Vice President for Cancer Control Interventions at the American Cancer Society, meaning that our section addresses those things that are known to be effective and try to figure out how to get them implemented at the practice level, at the community level. Things like colorectal cancer screening, breast cancer screening, HPV immunization, etc. I also am on the steering committee of the National Colorectal Cancer Roundtable, which is an organization that was started by ACS and CDC over 20 years ago now, with the sole mission of improving colorectal cancer screening in the US and therefore impacting the course of the disease. I have been asked to speak specifically today about the efficacy and value of stool-based testing. So I'll be giving you the underpinnings, the scientific underpinnings for much of what you'll be hearing in upcoming weeks. I also was asked to talk a little bit about evidence-based interventions, specifically as they relate to stool testing and colorectal cancer screening. So a lot to cover, and I'm going to dive right in. This year in the US, we expect almost 148,000 new cases of colorectal cancer. In Colorado, there'll be over 2,000 of your friends and family and citizenry who are going to be affected. More than 53,000 people are going to die of this disease in the US, and about 700 of those will be in Colorado, making it the second leading cause of cancer death, both in the US and in Colorado. However, dramatic improvements have been seen in colorectal cancer deaths over the last 40 years. In particular, you can see during the period of time between 2000 and 2010, a 27% drop in just that one decade in colorectal cancer mortality. So clearly we're doing some things right. There are now more than 1.5 million Americans who are living either with a past diagnosis of colorectal cancer for which they've been treated effectively, or who are currently still dealing with the disease. But our ability to positively impact people's lives, even after diagnosis, is huge. Approximately 40% of cases and deaths from this disease, however, are entirely preventable if we just use the tools that we have available to us, including stool testing more effectively. It's estimated that more than 500,000 cases have been prevented over the last 3 decades, primarily by polyp detection through either screening colonoscopy, or in many cases through colonoscopy because of a positive stool test. So how does screening impact this disease? Number one, helps us find those polyps. If we remove polyp, we keep cancer from ever occurring. And that's something many of your patients aren't aware of. So you want to be sure to really impress upon them the fact that screening is not just about finding cancer early. It's about preventing it in this case. In addition, screening does lead to earlier detection of the cancer. If we wait until people are symptomatic, there's a much greater likelihood the disease is going to be at later stages, and therefore survival not as good. So finding it early is good. And that's illustrated by this graph at the bottom here. You can see that for individuals who have colorectal cancer that is diagnosed while still localized, has not penetrated the colon wall, 90% of those people are going to be alive 5 years later. 90% 5-year survival versus only 14% for people who have metastatic disease, that distant disease at the time of diagnosis. Unfortunately, right now, only about 4 out of 10 people in the US are diagnosed at that early localized stage. So we're missing a lot of opportunities. In Colorado, how are we doing with screening? Well, this is 2016 data from CDC, but you can see that overall your screening rate was, compared to the US, almost exactly the same as the overall US average. With Colorado at 67.5 and the US average at 67.3. You can also see that there's some variation. And Colorado is actually one of the few states where the African American population rates are very, very similar to that of whites. There's a bigger gap in many instances, but you can see there's a huge gap between Hispanic Latino rates and that of the white population. You also can see here at the bottom left that if you are uninsured, you are almost 2/3 less likely to be up to date with screening. There's a huge gap between the insured and uninsured population. A very small gender gap. As a matter of fact, women in 2016 were a little more likely than men to be up to date with screening in your state. And then you also see there's a significant age discrepancy with people in the Medicare population, 65 to 75 years, actually at 77%, very close to that 80% mark that the National Colorectal Cancer Roundtable set for the nation. However, for people at the younger end of the spectrum, 50 to 64, only 62% of those. And I don't have Colorado specific data, but we do know that in 2016, across the US, among individuals aged 50 to 54, the youngest end of that spectrum, less than half were up to date with screening. So we still have a lot of disparities in screening rates based on not just race or ethnicity, but also age and to some degree gender. Now, these are the colorectal cancer screening guidelines from the ACS on the left. These were last updated in 2018, and the Preventive Services Task Force on the right. And as you can see, if you look specifically down at acceptable test options, those lists are essentially identical. As a matter of fact, the only major difference between the USPSTF and the ACS recommendation is the age at which we recommend starting. In 2018, we moved from the traditional start at age 50 to recommend that everyone at average risk start screening at age 45. I don't have time to go into the evidence behind that recommendation, but I will say that evidence is very solid. And as a matter of fact, the Preventive Services Task Force is right now doing an evidence review in consideration of updating their guidelines, and they've asked us for all of our data and information, so I know they're looking at that issue. I also think it's important, however, to recognize that there's some individuals who are not at average risk. There are some individuals who are at significantly higher risk of developing colorectal cancer, and it's imperative that you identify these people in your practice, because waiting till 45 is frankly too late for most of these folks. And certainly waiting till 50 is far too late. These are people who have a personal history of adenomatous polyps or who previously had colorectal cancer, also individuals with inflammatory bowel disease. Once they've had Crohn's or ulcerative colitis for more than 7 or 8 years, their risk rises pretty dramatically. In addition, family history. A family history of colorectal cancer doubles or even triples the risk. But while I'm sure everybody on the line who takes care of patients asks about a family history of cancer and colorectal cancer, I'm also willing to bet most of you do not ask about a family history of adenomas. That can double the risk of developing this disease. Consequently, it is important that this be included in your family history assessment as well. And then finally, there are hereditary syndromes. All of these conditions are important to recognize, and you need to be asking patients much earlier in life, in their 20s and 30s, because many of these individuals need to get started screening at a strikingly earlier age, sometimes in their 20s or 30s. And colonoscopy is the only acceptable approach to colorectal cancer screening for many of the people in these categories. So you have to collect this information. Even if you're going to be very aggressive with stool testing in your office practice, you cannot just blindly offer stool testing to everyone. You've got to do this risk assessment. So let's talk about stool test. So there are two broad categories of stool tests. There are tests that detect blood, which are commonly referred to as fecal occult blood test, or FOBT. But within that moniker, within that test that find blood, there are actually two different major categories, one being guaiac-based fecal occult blood test, and those are the older versions that have been around for 50 or 60 years. And I'll talk a little bit about those. And then there are newer tests, fecal immunochemical tests, which actually aren't that new. They've been around for 30 years or more now, but only the last decade or so have they really taken off in the US. Then the second category of tests are those tests that look for aberrant DNA. They look for DNA mutations that are associated with polyps or cancers. Right now, there's only one such test that's available in the US, and that test is Cologuard. And Cologuard is actually a twofer. It combines the tests that look for abnormal DNA with a high quality FIT test. So when you get a Cologuard result back, you're actually seeing the results of two different tests combined. They don't break out which is positive, which is negative. But positive Cologuard implies that you have either DNA mutations or a positive FIT test. Again, these tests are only appropriate for individuals who are at average risk. So I'm now going to talk briefly about each of these different types of testing. Guaiac-based fecal occult blood tests, as I mentioned, have been around for more than 50 years. These are actually the tests that led us to begin screening for colorectal cancer at the population level, because 3 randomized controlled trials, all of which were started back in the 1970s or 80s and published in the late 80s, early 90s, all showed that screening for colorectal cancer using Guaiac fecal occult blood testing could decrease mortality from the disease. There was also a 30-year follow-up paper that was published in the New England Journal of Medicine in 2013 that demonstrated that among those patients who had been entered in that trial 35 or 40 years prior, that even looking 30 years down the line, those individuals who were part of the trial arm were were strikingly less likely to die of colorectal cancer. So not only did they have a short-term benefit, but it had an enduring benefit from colorectal screening. But Guaiac tests have a number of limitations, and because of that, they're being replaced in the vast majority of practices in the US now. These limitations include the fact that you need to collect specimens from 3 separate bowel movements in order to have an adequate specimen. You need to recognize that these tests are very heavily influenced by a variety of different foods and medications. That is, both false positive and false negative results can occur as a result of something that people eat or some medicine that they're on. The findings are non-specific, that blood can be anywhere in the GI tract, or frankly, even someone who had a nosebleed prior to collecting a specimen, they have swallowed some of that blood and caused a positive result. And then finally, these tests have low sensitivity compared to fecal immunochemical tests. The vast majority of studies that have looked at this issue find that older versions of Guaiac testing have something like 20 to 25% sensitivity for cancer, which is much, much lower than I'll be sharing with you regarding FIT. So if you are continuing to use a Guaiac test for whatever reason, there's only one Guaiac test that is recommended for colorectal cancer screening by any guidelines, those of ACS, USPSTF, or any other organization, and that is Hemocult Sensa. That is the only brand that's been demonstrated to actually have sensitivities that make it sufficient as a screening tool. Fecal immunochemical tests, as I mentioned, have been around for 30 plus years, but have only really grown in use in the US over the last decade. These tests work in a very different way than Guaiac tests. They actually use a immunoassay. So it is an antibody that is specific for human blood that detects evidence of blood in the stool. So this makes it a much more specific test than Guaiac testing. And it makes it specific both for human blood, so you don't get interference from a rare steak as you might with the Guaiac test. It's also more specific for lower GI bleeding, because the portion of the hemoglobin molecule that is assessed by this antibody is actually very sensitive to upper GI enzymes, so that nosebleed that I mentioned earlier, or even someone who has an ulcer or esophagitis, because that blood has to track through the entire upper GI tract before it exits the body, in many instances, it'll be denatured. So if you have a positive FIT test, it is much more likely to be bleeding from the lower GI tract. That's not 100%, but it is much more likely. There have been no foods or medications that have been reported to cause either false positive or false negative FIT test. Most of the brands that are available in the market now only require either 1 or at most 2 specimens, as opposed to 3 specimens required for all types of Guaiac testing, including Hemocult Sensa. And these tests are have much higher sensitivity for cancer than do guaiac FOBTs, with sensitivities reported around 70% for cancer for most high quality fits. Recognize I keep talking about high quality fits, and I'll talk about quality in a moment. And then it is important to acknowledge that these tests are more expensive than traditional guaiac tests. However, they're also reimbursed at a higher rate. So most practices that transition from hemocult to a high quality fit find that it's a relatively cost neutral shift. Now, these tests have some real advantages over colonoscopy. For one, they're far less expensive. I'm sure that most of you are aware that colonoscopy, particularly for your patients who are either uninsured or don't have good insurance coverage, can be a very expensive proposition. I hear, as I travel around the country, the low end for the cost of colonoscopy is usually somewhere in the $2,000 to $2,500 range, and the high end I hear as high as $5,000 or $6,000 for that procedure and all the associated assistance that's required. Medicare reimbursement for stool testing is somewhere in the $20 to $25 range. Even for uninsured patients, $20 to $25 test is often within reach for them. There's no bowel preparation required. And if you talk to patients about colonoscopy, the bowel prep actually turns out to be one of the primary barriers. They don't know anything about a colonoscopy, they've never had one, but their cousin's friend from up the street can tell them all about how horrible that prep was, and they don't want anything to do with that. These tests are done in privacy at home, which turns out to be a really big deal for a lot of patients. Many patients are concerned about a lack of privacy or a lack of dignity from any sort of procedure related to their rectum or their behind. And consequently, the fact they can go in the bathroom and close the door and collect a specimen turns out to be very attractive. Patients do not have to take time off work, which is also a big deal. As you know, with colonoscopy, essentially every colonoscopy provider requires that patients be accompanied. So they're not the only ones inconvenienced. They also have to bring in a friend or a family member to take off the day from work, to bring them to the procedure, wait with them, and then take them back home afterward. These tests are non-invasive, which is also important. Colonoscopy is a good test, an overall safe test, but somewhere between 1 in 500 to 1 in 1,000 individuals undergoing a screening colonoscopy are going to experience some significant complication, including bleeding and perforations. I have never had or heard of a patient experiencing any complication related to collecting a stool specimen. And then finally, these tests serve a real purpose if colonoscopy is a limited resource in your environment, or if it's hard for patients to get to it because of distance or geography or transportation issues. You only have to do colonoscopies on those patients who have a positive finding on stool testing, which is a really big deal, actually. This graph, this illustration was put together by Dr. Gloria Coronado, who does a lot of research on fit testing. And her estimates say that if you are trying to screen 1,000 patients and sending all of them for colonoscopy, you're going to refer 1,000. Most of them will show up, but within that population of 1,000 patients, there are only going to be a few cases of cancer. So consequently, if you do close to 1,000 colonoscopies, you're going to find 1 or 2 cancers. That is 1 out of every 400 to every 1,000 colonoscopies that you perform. On the other hand, if you refer your patients first to stool testing, number one, you can screen many, many more patients. You can easily screen 2,000 patients with stool testing and spend far less than you would for that 1,000 colonoscopies. But not only that, fit testing allows you to narrow down the pool of patients and only have to do colonoscopies on those who are positive or have been identified as being therefore at higher risk. And patients who have a positive fit are much more likely to have some abnormality, including cancer. So you do many, many fewer colonoscopies. If you screen 2,000 patients, in general, FIT positivity is somewhere around 10%. So that means you're only going to have about 200 patients who have a positive FIT and need to go under colonoscopy. However, among those 200 patients who undergo colonoscopy, you're going to find many more cancers. You're going to find one cancer out of every 10 or 20 colonoscopies. So you're going to find a lot more cancers, even though you do far fewer colonoscopies. So you've spent a lot less money, you've subjected a lot fewer people to the potential hazards and just the trials associated with undergoing colonoscopy, and yet you have found more cancers. This is why every country in the world that has organized colorectal cancer screening programs uses stool testing, and the vast majority of those now FIT testing as their primary approach to screening. The US is the only major nation that uses colonoscopy as their main colorectal cancer screening tool because of this simple approach. The fact that you're going to find many, many more cancers, spend far less money if you are using stool testing as your initial approach. Now, another important thing to keep in mind is primary care clinicians have very strong feelings in many instances about the best test. And the vast majority of primary care clinicians say that colonoscopy is the best test for colorectal cancer screening. However, they will also acknowledge that many patients either face barriers to getting a colonoscopy or they're simply not willing to have it done. Unfortunately, in a lot of environments, that's where the conversation stops. The clinicians know that that patient either doesn't have access or isn't going to do the test, yet they don't offer alternatives. And it's been shown that practices that are focused solely on colonoscopy as their only screening tool are practices that are destined to have lower screening rates. Now, many clinicians do use FOBT or FIT, but many of them also will say they feel they're offering second-class service to their patients. They're using a second-class test. But in many instances, they really do not appreciate the profound difference between old stool testing, Hemocult, and other basic guaiac tests versus newer tests like FIT testing or FIT DNA testing or Cologuard. So they question the effectiveness of these tests, but they don't appreciate how much the technology has improved. And the final thing is, very few primary care clinicians move beyond their own belief and perceptions of what's best and actually ask their patients, well, what are your preferences? When you ask patients, you get a startling answer in many instances. This is a study published a few years ago that took 1,200 patients, all of whom were due for colorectal cancer screening. They educated all the patients about why screening was important. And then one group was told, go get a colonoscopy. Won't cost you anything, just get the test done. Second group was told, you can have stool testing, you can do colonoscopy, you choose. Third group was told, take these stool test kits, collect specimens, and bring them back to us. What they found at the end of the study, that dark bar there in the middle, that's the colonoscopy group. 38%, less than 4 out of 10 people who were offered a free colonoscopy actually got the test done. On the left, the gray bar, FOBT, people who were only offered stool testing, and these were the 3-card Hemocult test, or Hemocult Sensa, I believe they used here. But they had to collect 3 specimens, yet 2 out of 3 people, 67%, actually completed the screening. And then the choice arm, where they were told you can have either one, colonoscopy or stool testing, you choose. Again, 2/3 of people got screened, and notice, more people actually chose stool testing over colonoscopy. A number of studies have looked at this issue and found anywhere from 1/3 to half of patients, if given a choice, will choose stool testing over colonoscopy. But in the vast majority of practices, patients are never given a choice. As a matter of fact, the ACS has done some work, or actually NCCRT commissioned some work looking at unscreened patients over the age of 50. And in our initial round of this work, we found that the vast majority of those patients had no idea there were any screening options other than colonoscopy. So patients simply are not aware that they have options. You want to make sure to give them that information. Now, I mentioned earlier the sensitivity that we've seen with FIT testing, and this is a meta-analysis that was published a few years ago that looked at a large number of studies from the last 15 or 20 years looking at FIT testing, and found that on average, FIT tests find about 7 out of 10 cancers that are present at the time of that testing. So 70% sensitivity for cancer, which is pretty good for a non-invasive test. However, that 70% still means that about 3 out of 10 cancers are not going to be detected by that first screening test. That's why it's imperative that the screening be followed up every year. You need, if you're going to embark on stool testing, you need to repeat the testing every year. So hopefully if you do have a false positive result, if it's one of those 30% of cancers not detected at the first round, that it'll still be found at the second round or the third round while it's still in a relatively earlier stage. This is data from actually the Colorectal study I'll be talking about in a little more detail later. But again, this was 10,000 plus screening colonoscopies, and they then did FIT testing on all of those individuals. And the FIT test in that instance had about a 74% sensitivity for cancer. Again, very much in line with the other studies that have been previously looked at. Notice they also looked at the green circle, advanced precancerous lesions. Those are the kinds of polyps that are known to progress to cancer. And this FIT test found essentially 24% of those. So you miss a lot of polyps, but you do find about 1 out of 4 significant polyps with stool testing as well. The efficacy of stool test is, at this point, it is absolutely undeniable. This is a study that I mentioned earlier, that 30-year follow-up of individuals who were part of the early screening trials using low sensitivity guaiac test. And as you can see, over the 30 years that the control arm, individuals in that control arm were much more likely to die of colorectal cancer than individuals who were screened either annually, that's the blue line there at the bottom, or even biennially every other year. So both annual and every other year stool testing led to a significant decrease in colorectal cancer death, even 30 years after these trials ended. When the Preventive Services Task Force did their last guideline update back in 2015 and 2016, they commissioned a group of modelers, people who take information from a wide variety of studies and pull that information together and make some estimates, outcome estimates, based on all that published data. And what those modelers did was look at screening by various approaches and estimate how likely it was to decrease mortality from colorectal cancer. So CLL-10Y, you're at the far right here, 24. They estimated that for every 1,000 individuals screened with colonoscopy every 10 years, 24 deaths from colorectal cancer would be averted. Think about that for a moment. How many things do we do in medicine that for every 1,000 times we do it, we prevent 24 people from dying? Or let's cut that down and say for every 100, we prevent almost 2.5 deaths every 100 times we do this procedure. That is really a very significant impact. At the other end, FIT1Y, and next to it GFOBT1Y, that's FIT or guaiac testing every year. As you can see, 22 deaths averted. Now, is 22 less than 24? Sure it is. Is 22 strikingly less than 24? Actually, that's a pretty small difference. Again, when you magnify this to the population level, when you look at the fact that FIT testing is potentially much more accessible to many, many more people, the fact that you can prevent 22 deaths for every 1,000 individuals screened with stool testing is a really, really impressive accomplishment, again, for a non-invasive test. As I said earlier, there are some important quality aspects to keep in mind with stool testing. One is you've got to do that risk assessment because these tests are only appropriate for average risk patients. Two, you have to be using one of the high sensitivity versions, either Hemocold Sensa, which is the only high sensitivity guaiac test that has data in the medical literature, or a high sensitivity FIT. And then that annual retesting, as I stated, if you're going to miss 30% of cancers, you cannot stretch out the rescreening interval. You need to be rescreening every year. Other important quality factors, you have to follow up every positive FIT. Every positive FIT or every positive guaiac test is cancer until proven otherwise. But unfortunately, in most of the published literature, about 1 out of 3 individuals with a positive test have no evidence of a colonoscopy within the next year. So we are missing a lot of opportunities there. People who have already been now identified as being at higher risk of having cancer or polyps with no colonoscopy, it is a totally empty exercise. And there's now been some very good work done, particularly out of Kaiser, that's looked at the long-term outcomes and found that people who have a positive FIT and do not have a colonoscopy within the next 9 to 12 months are at higher risk of being diagnosed with colorectal cancer and higher risk of having advanced stage disease at the time of diagnosis. One of the things that I often see or often hear about is clinicians questioning whether a positive test is actually a true positive and therefore repeating a stool test. As I said earlier, every positive stool test is cancer until proven otherwise. Repeating that stool test is not the answer. There is no evidence demonstrating any value in that. And indeed, there are suggestions that you're much more likely to end up delaying appropriate evaluation and treatment if you waste time repeating those tests. It is important, therefore, when patients are making a choice, if your patients actually have the option of colonoscopy versus stool testing, it's imperative that they understand up front, if you have a positive stool test, you must follow through with the colonoscopy. So this won't come as a shock to them if the test turns out to be positive. The other thing is, because of a quirk in how the Affordable Care Act is currently interpreted, this colonoscopy might lead to some cost sharing for them. I don't really have time to go into those details. The patient should know that there are some potential financial implications associated with choosing stool testing first if they have access to both stool testing and colonoscopy. Another shocking but very persistent issue or problem with the stool testing is inappropriate collection of samples, and this is maybe the most important quality issue. There is zero evidence that a specimen collected by digital rectal exam is an appropriate screening test, either using guaiac or fecal immunochemical test. The largest study that looked at this had over 2,000 patients, all of whom, again, were scheduled for screening colonoscopy, had specimens collected ahead of time by digital rectal exam. And then at the end of the study, they looked at those patients who were found to have cancers. 21 patients had cancer on those screening colonoscopies. Of those, 19 patients had normal findings on that digital rectal exam sample. So this test missed 19 out of 21 people who had cancer at the time that specimen was collected. Any test that misses 19 of 21 cancers is not a useful test. Now, this approach has not been repeated with FIT testing, but there is zero evidence in the medical literature that digital rectal exam specimens are useful for FIT or for Cologuard. Therefore, digital rectal exam is not an appropriate approach for colorectal cancer screening. Indeed, DRE specimens are not acceptable in any fashion for colorectal screening. Yet, the latest data that we have on this showed that about 25% of primary care clinicians still use DRE sampling. There are no quality studies, no high quality studies that show that this is useful. There are no FDA approvals for any test using this approach. It also does not count in calculating your screening rate. If you are within a federally qualified health system and using UDS or insured, commercially insured populations collecting HEDIS data, both HEDIS and UDS specifically state that digital rectal exam samples do not count as colorectal cancer screening. And they're not, this approach is not recommended by any manufacturer. However, there are a number of manufacturers' reps apparently around the country who will tell clinicians in private, oh yes, you can do digital rectal exam sampling. There is no data. Ask them to show you the data. Ask them to show you where their manufacturer's consumer information spells that out, and they simply can't. Now, another important element to be aware of is not all fits are created equal. The FDA actually only clears fits or approves fits for use in the US based on their ability to find blood. They don't have any requirement that they show that they can find cancer or find polyps. And it turns out this is a really important issue. A recent study looked at all of the different fits that have gone through the clearance process in the US and found that over the last 15 years, I think, about 60 different FITs have been cleared for use. And as of the time of this publication, which was 2017, I believe, there were 26 fits that were currently being marketed in the US. Of those, only 6 had any data demonstrating their ability to find cancer or polyps. Most of these tests are able to get their FDA clearance by comparing themselves to any other test that's already received FDA clearance. So guess what? These fits are comparing themselves to guaiac tests that are no longer recommended by anybody as a screening test. So they show that they are as good as Hemocult or Hemocult 2, and they're able to get into the US marketplace. But again, 6 of these different brands have gone beyond that, and they have some data in the medical literature showing that they can either find polyps or find cancers or both. And these tests are highlighted here. And this is an extensive, almost 2-year combing through the literature looking for data in order to find these 6 tests. So these are, if you are using a fit that is not on this list, I would encourage you to either talk to your manufacturer's rep and ask them to show you the data on polyp and cancer detection, not on blood. They'll all tell you, oh yeah, we show 99.9% sensitivity for blood. That's not good enough. You need to know if they can find polyps or find cancers. If they don't have that data, then I would encourage you to talk to whoever in your system makes these decisions and ask them to look at these tests and consider switching over to one of these tests. As you can see here on the far right, the number of stool samples, most of these require only 1 sample. A couple of them, it can be 1 or 2 samples, and there's usually a small increase in the sensitivity by adding a second sample, but in many instances, it's very small. And then Hemocult ICT is either 2 or 3 samples. But all of these tests have some data demonstrating that they can find cancer or polyps. So I encourage you to use a test that has some data support. Now, that table I showed you is actually from this tool, which is the clinician's reference on stool testing, and it encapsulates a lot of the information I've shared with you about quality stool testing and includes that table. And you can find this at the NCCRT website. Switching gears now, I want to talk a little bit about stool DNA testing. Now, guaiac test and FIT test are both dependent entirely on blood. There has to be blood. However, not all cancers bleed continuously, and not all polyps bleed. So the opportunity to miss cancers and polyps is a lot higher if you're limited to looking for blood. What stool DNA tests instead look for are DNA mutations that are known to be associated with polyps or cancers. And they do this by interrogating colon cells that are in that stool specimen. As stool moves through the colon, it scrapes off cells all along that pathway. So there are a number of colon cells included in every stool specimen. And the folks who make these DNA tests have figured out how to interrogate those specific cells and look for those DNA abnormalities. As I mentioned earlier, there's currently only one test in the market, and that is Cologuard. And Cologuard actually combines this test for DNA markers with a high quality fit, one of those fits that's on that table that I mentioned earlier, or that I showed you just a moment ago. Now, these are, again, the results from the Cologuard study. I showed you and focused on the fit arm at the far right earlier, but this is looking at the combination of stool DNA test and fit. So if you have a positive finding from a Cologuard test, then it either means the fit was positive or the DNA was positive or that both were positive. What they found was a positive Cologuard test was associated with 92% sensitivity for cancer among those 10,000 plus patients who underwent screening colonoscopy. So 92% sensitivity for cancer. And the blue box there, the advanced precancerous lesions, those polyps that are likely to progress to cancer, 42% sensitivity. So you're still going to miss most polyps. You're going to miss almost 6 out of 10 polyps, but you're going to find more polyps with Cologuard, and you're going to find more cancers. However, that comes at a cost. The red box there is specificity. As you can see, the specificity for Cologuard is essentially 87% versus 95% for fit testing alone. What that means is you're going to end up with more false positives. So about 13%, or one out of every 6 positive Cologuard test is not going to be associated with cancer after you go through the colonoscopy. So you're going to send more patients for colonoscopy with Cologuard testing. So it's important, again, that patients who choose this method recognize, yes, you're increasing the likelihood that you will find cancer. You're lowering the chance that a cancer will be missed. You're increasing the chance of finding polyps, but you also are increasing the chance that you'll have a colonoscopy and nothing abnormal will be found. So patients should understand what that means. So fit DNA, or Cologuard, is now included in guidelines from both the ACS and Preventive Services Task Force. It's also included in quality measures. Both HEDIS and UDS now include a Cologuard test as a completed colorectal screening. It is cleared by the FDA for colorectal cancer screening, and they actually went through a process after the ACS guidelines and demonstrated that that Cologuard is effective for individuals between ages 45 and 49, as well as the 50 plus population. So they actually have an indication or approval from FDA for screening beginning at age 45. The company recommends that rescreening be done every 3 years. And that's because, again, there are, there is a potential miss rate, as I showed you. Even if you're finding 92 or 93% of cancers, that still means 7% of cancers may be missed. So they recommend the 3-year rescreening interval. Medicare reimburses for this test for individuals between the ages of 50 and 85. Medicare reimbursement is about $500 every 3 years. The cost for individuals who don't have insurance coverage, don't have Medicare or commercial insurance coverage, is somewhere in the range of $600. Private insurance coverage, according to the company, has increased very dramatically since it was added to the Preventive Services Task Force recommendation. And I've been told by company representatives that somewhere between 70 and 80% of commercial insurers in the U.S. now cover this test. That's not substantiated. We have not done our own research to find that. But the basic issue is if you have a patient who's interested in Cologuard, you should have them contact their insurance company just to make sure it's going to be covered. Or if they contact the company directly, the company may assist them with finding out about their insurance coverage. Every positive Cologuard is cancer until proven otherwise. Therefore, every patient needs to have that follow-up colonoscopy, and they should know that up front before choosing this test. And they should know that, again, if they choose this test, then this may be viewed by their insurer as their screening test. And if a colonoscopy is required because of an abnormal finding on Cologuard, they may end up having to pay a copay or a deductible that they may not have had to incur if they had chosen colonoscopy as their initial screening test. Finally, $600, $500 to $600 every 3 years is, a fairly hefty price tag. But one of the things the company has done is they include their own patient navigation component, and that is significant for a lot of environments. We know that for stool testing in general, if you just give the patient a kit and send them home and hope for the best, you're going to get somewhere between 25 and 30% return rate on that stool kit. The Cologuard folks, once the clinician writes that prescription and they get it in hand, they will reach out to the patient and confirm their address because they're going to send the kit out to them. They will make sure the patient understands how to collect the specimen, and then after 7 or 10 days, if they've not received that specimen back, they will hound that patient relentlessly until they get that specimen. And consequently, they have somewhere between a 60 and 65% return rate. So that is helpful in terms of getting patients to complete the screening process. All right, in the last couple of minutes I have available, I just want to introduce you all to the concept of evidence-based interventions. And this information comes primarily from the CPCRN putting public health evidence into action training workshop. So what are evidence-based interventions? These are interventions that have been found to be effective in well-designed research trials, and these can be programmatic interventions, policy interventions, or strategic interventions. The evidence sources that they use include the systematic reviews. They include individual research studies on certain kinds of programs. There is a little bit of information based on practitioner reports. And then there are practice-tested or promising interventions. Those would not make the cut in most instances for what are considered evidence-based interventions. Really, the research studies and systematic reviews provide the primary background for most of these evidence-based interventions. Now, why are EBIs recommended? Well, one, again, we have research that demonstrates that they have some level of effectiveness. So there is some credibility associated with utilizing these. And often, in most instances, actually, these different approaches have research protocols or materials that have been already developed in support of the original studies. And consequently, you have a ready-made packet that helps you outline your approach. So it's really a matter of building on what works and not continually recreating the wheel. Some of the common resources to help you find these interventions include the community guide or the community guide for preventive services. And then there is the county health rankings that talks about what works for health and has recommendations about different kinds of programs. And then there is the NCI's RTIPS, or Research Tested Interventions Program website, that, again, includes a lot of information and background regarding evidence-based interventions and the tools and resources that are utilized. So if you're looking for EBIs related to not just colorectal cancer screening, but cancer screening in general, or other kinds of public health interventions, these are good places to start. When we talk specifically about cancer screening, the kind of evidence-based interventions that have been shown to be effective include client-oriented interventions, provider-oriented interventions, and then interventions that are designed to increase access. Those are the three broad categories. And then, as you can see, under each of those are a variety of sort of sub-elements. So you can do things specific to provider incentives or provider education, and there are studies that have looked at all of these. Moving specifically to colorectal cancer, the community guide, the green buttons here are things that are recommended, and then the yellow diamonds are interventions for which there is insufficient evidence. Now, it's important to recognize insufficient evidence does not mean it doesn't work. It means that there has not been enough evidence in high quality studies that's been published in the medical literature demonstrating whether or not this is effective. So for colorectal cancer, client reminders have been shown to be an effective approach in a number of different studies. Whereas client incentives, you see, you get that yellow diamond. Doesn't mean that incentives don't work. It means that there's not enough evidence in the literature to say yes or no about incentives. So the things that have been shown to work for colorectal cancer from the client standpoint are client reminders, small media, so brochures, pamphlets, educational tools, one-on-one education, and reducing structural barriers, so things to increase access to screening. Things like changing clinic hours or bringing screening to where the clients already are. From the provider the provider standpoint, provider assessment and feedback. So that is actually measuring screening rates and letting providers know how they're doing. And provider reminder and recall systems. All of these things with green buttons have been shown to have a beneficial impact on colorectal cancer screening rates. And then there are what are called multi-component interventions, where you combine let's say client reminders plus group education plus provider assessment and feedback. So you're doing multiple things. And there are, again, a number of recent studies that have demonstrated that combining multiple EBIs gives you a better outcome than simply using any single EBI. Okay. My slides have quit advancing, so I don't know. Ah, there we go. All right, so there are a number of different approaches that have evidence behind them. If you go to our tips, two things that popped right out at me were automated telephone calls, which are essentially client reminders, but you automate calls to clients, and they have scripts for these. They have information on what kind of settings that they were researched in and how well they worked. The second here on the right is FluFit and FOBT programs, and these are programs that take advantage of the fact that people are already oriented toward getting flu shots every year. They know that's a wellness issue, and you combine colorectal cancer screening, which is also a wellness or preventive issue, with flu shots. So there are a lot of these kinds of programs that have already been demonstrated to be effective, and you can find these at the websites that I mentioned just a couple of minutes ago. The National Colorectal Cancer Roundtable has a resource center. It has a wealth of tools and resources that can be helpful On the left here, in particular, the steps for increasing colorectal cancer screening rates. Any primary care system that's interested in improving their screening rates should take a look at this tool. There's a lot of different guidance and a lot of different support and links to a large number of other tools that you can use to help boost screening rates within your practice. The NCCRT Resource Center, as I already mentioned, has a wealth of different tools and resources, as does ACS at cancer.org/colonMD. We've combined all of our different colorectal cancer screening tools. And I think I am right up against the hour, so Amy or Andy?
Yes, so Durado, that was fantastic. Amy and I were just looking at the time, and I said, wow, the time has flown, and we both agreed that you've been so thorough, Durado, that there might actually be questions, because it's amazing. So I know that we're right at the top. We will spend 5 minutes. There's nothing that's come through from the chat right now in terms of direct questions. But Durado, let me ask you the one question. I know this is like a little bit outside of the stool-based testing, and I know there's a lot of questions right now about even questions around blood testing. And if I'm correct, in this USPSTF guideline review, they're going to be looking at evidence for stool DNA. And is it your understanding also that the blood test is going to be in this review as well?
Yes, they're definitely looking at the blood test. There is already one blood test that has been cleared by the FDA for use in the U.S. as a colorectal cancer screening tool. However, that test is not included in the guidelines from ACS or the U.S. Preventive Services Task Force. And that's largely because it has, well, two elements. One, its overall sensitivity for colorectal cancer is, we think, less than optimal, but there is no data regarding its ability to detect polyps. So a test that misses a significant number of cancers and all polyps, there are concerns about that test. Now, that's both the ACS and the Preventive Services Task Force guidelines were based on data that was available at the time we did those reviews, and there have been some additional studies published. Beyond that, however, there are a couple of other blood tests that, to my knowledge, have not yet received FDA approval, but may have better test characteristics. So I do think it's only a matter of time before we actually have a blood test that's going to be part of this menu of options for colorectal cancer screening.
Great, thank you, Durado, because I know that's something that's come up. So it's interesting. I think we definitely were on the movement of talking about broader stool-based testing beyond FIT and FOBT, but hopefully those beyond colonoscopy and although a blood stick is invasive, that it's not the level of invasiveness of colonoscopy. So as those options grow, that chart that you showed about patient preference, hopefully there will be continued opportunities to increase and bolster those screening rates. Durado, in your opinion, what do you think, if you had to give advice to a clinic system who is just getting ready to start really engaging in stool-based screening as a population approach for average risk, what would be your one piece of advice for folks as they get ready to start?
Education, education, education. Make sure that all of the providers and all of the support staff understand the value of testing and the importance of options, and understand how to talk to their patients about this issue. There are, again, you're very familiar, Andy, with the tools and resources NCCRT has developed, and we've developed communications guides that help address some of the misperceptions, fears, concerns that patients may have, and provide some recommendations on how to address those closely held patient beliefs across cultures. We've got guides for Asian American populations, for Hispanics, as well as a general communications guide. And we also, in our recent tool, break down rural versus urban dwellers and a variety of other characteristics that may influence people's willingness to get screened. So really understanding number one, the value of screening, the importance of really adopting it at a practice-wide level, and making sure everybody understands their role, and then two, making sure everybody really knows how to talk to patients in a way that helps patients appreciate the potential life-saving impact this can have on them.
Great, thank you so much. I didn't see any other questions come up in the chat. We will leave the line open for another few seconds to see if anybody pops in with pressing questions. While we're doing that, if you want to come off mute if there are any questions, I know Elsa has provided the evaluation link in the chat. Amy, anything else as we're waiting for any additional questions to pop in?
No, the evaluation was the big one. Just please, we really, really appreciate when you take a moment to fill those out. It helps us and it helps our speakers as well when we get some good feedback. So write in the chat and then we'll send it in a follow-up as well.
Great. Any other final questions? And if anybody wants to come off mute, we will be quiet for about 5 to 10 seconds just to give everybody a chance. Okay, that's about as much silence as I can handle. So, okay, well, everyone, Durado, if you can stay on for half a second. Thank you, everyone, for attending. I know we had almost 30 people on, and we had about that many people who said they couldn't make it today, but we'll be watching this series, and we'll be tuning in for Durado's this first session. And keep up on the calendar because they're going to be coming several more, as Amy noted, and this is part about the implementation next. So thank you so much, everyone, for attending today, and fill out that evaluation. Durado, any closing thoughts?
No, again, appreciate the opportunity to be part of this, and hopefully if anyone has questions afterward, just send them on to Andy and I'll do my best to address.
All right, and a huge thank to Amy and to Elsa for helping make sure that this goes swimmingly today, and have a great weekend, everyone. So very good.